been operating laparoscopically and has been involved significantly with endometriosis surgery and also bowel surgery for endometriosis. I saw Jeff give a lecture at the AGES meeting earlier this year in relation to the management of endometriosis and taking into account fertility preserving measures in women with endo, particularly when it comes to attacking the ovaries with endometriomas. And there seems to be a growing body of evidence that we may need to reconsider how we approach endometriomas, particularly if women have a low or poor ovarian reserve. And so thus, I've invited Jeff to speak to us today in relation to managing ovaries in the context of AMH. So thanks very much, Jeff.
Thank you very much, George, for your kind invitation to speak today. When I was first asked to speak about endometriomas, I thought, what a boring topic, it's all been said before. And then I came to realise just how much and how radically my own practice has changed. And I think, I hope I have some important messages for you. In the world of endometriosis, endometriomas are unique in that we have the opportunity to establish a pre-operative diagnosis. And while George is working away, beavering away, trying to give us that ability with colorectal disease, there are only very few specialised sonographers around the country who really are giving us valuable information. Not so with endometriomas. We can have an accurate diagnosis of an endometrioma in the ovary, even less than a centimetre in diameter. So I want to talk to you a little bit about the evidence base for managing endometriomas. And just briefly, I'm going to talk about medical and surgical management, outcomes in terms of pain and fertility, outcomes in terms of recurrence, and then focus on this very important issue of ovarian reserve. Medical treatment really has very little place in the treatment of endometriomas. It is true that you'll get about a 40 to 60% reduction in cyst size with, for example, using GnRH analogues. But the cyst size reduction is temporary, and 6 months later the endometrioma will be back to its original size. There have been absolutely no medical approaches demonstrated to improve fertility. And all of these rather historical randomized controlled trials looking at danazol, GnRH, Provera, gestrinone, danazol, a whole combination of very toxic synthetic progestogens and antagonists, show absolutely no increase in the odds ratio for subsequent pregnancy. And this has been well and truly established for 20 or 30 years that medical management really has no place in the treatment of fertility. What about surgical treatments? And there's been debate all around the world whether you should just simply aspirate the cyst, whether you should fenestrate it, whether you should ablate the internal active capsule of the cyst, or whether you should excise the cyst. In terms of drainage, recurrence rates understandably are extremely high because the active disease is still left in place, and there's this background risk of inducing infection. An endometrioma, after all, is the ideal culture medium, and I'll talk more about that later on. Laparoscopic aspiration, even when followed by GnRH. This small paper from Versellini in Italy showed a 100% recurrence, and again, why would you expect otherwise? There's been a lot of debate around the world whether ablation of a cyst is preferable and whether that should be done as a two-stage procedure, i.e. drain off the cyst, let it collapse down, and then go back and ablate the internal surface of the endometrioma. There's been debate about what sort of energy you should use, be it laser or electrosurgery. And that's been compared with the concept of stripping out of the cyst or excising it, excisional surgery. There are not many randomized controlled trials comparing ablation versus excision, but there are these two upon which many of the formal guidelines are based. There's Beretta's study showing a cumulative pregnancy rate after ablation of 23% versus a cumulative pregnancy rate after excision of 66%. And there's El Borzi who shows almost identical figures in terms of ablation versus excision. And if you graph out Alborzi's data, you can see the cumulative pregnancy rate over a 12-month period. And in fact, the spontaneous cumulative pregnancy rate after excision is quite respectable at about 60% of patients achieving a pregnancy. So it would seem fairly clear that when we treat endometriomas surgically, and especially by excision, that we are improving that patient's chance of achieving a spontaneous pregnancy. What about recurrence after surgery for endometriomas? And here are some, again, historical studies comparing ablation versus excision, and quite logically, full excision of the cyst seems to be associated with a reduced recurrence rate. And the one thing that ovaries do not like is undergoing recurrent surgery. Again, more about that later on. So this has led to a number of formal guidelines, such as this Cochrane review, which states that excisional surgery has a more favourable outcome in terms of subsequent spontaneous pregnancy. However, in women who may subsequently undergo fertility treatment, that is IVF, insufficient evidence exists to determine which approach is preferable. Here's an endometrioma in a young girl. She's 21, and I'm just going to run a little bit of video clip, I hope, to show you what's involved in stripping out an endometrioma. You can't make this surgery look pretty. The ovary is almost always adherent to the pelvic sidewall, and as you mobilize the ovary up from the pelvic sidewall, it invariably ruptures and releases all the chocolate material from within it, which, as you can see, we vacuum up while we're working. We then need to completely mobilize the ovary from the pelvic sidewall, and we're just using electrosurgery delivered through laparoscopic scissors to vaporize the tissue and free up the ovary. And when the ovary is fully mobilized, you'll then see that where the cyst is ruptured, it gives us an aperture into the inside of the cyst. And you are looking inside the endometrioma there, and now we need to develop a dissection plane and literally strip out the endometrioma from the underlying ovarian cortex. And we do that, as I say, you can't make this look pretty. We're stripping it out, and when the cyst, hopefully, in one piece, is stripped from the underlying cortex, you'll see, believe it or not, that there's actually quite good preservation of normal ovarian tissue. But when we lift that ovary up, always, there will be quite extensive underlying peritoneal disease involving the pelvic sidewall and the uterosacral ligament. What about outcomes in terms of pain after dealing with endometriomas? And there's virtually no studies in the literature. This is about the only one that I could find that looked at symptoms of dysmenorrhea, dyspareunia, and pelvic pain in general after ablation versus after excision. And certainly the recurrence of those symptoms is reduced in those patients undergoing excisional surgery. It is notable that ovarian endometriosis is always almost a marker for more extensive underlying peritoneal disease, as I just showed you in that video clip. And this is some of David Redwine's data. He looked at 1,785 patients, and only in 1% was there isolated ovarian disease. So this underlying peritoneal disease complicates the whole pain picture, and it's really impossible to distinguish between pain arising from an endometrioma, which I think is relatively rare, and pain that's arising from the underlying disease. So it makes the whole issue of pain just too hard to cope with. what interests me even more is the number of patients with severe endometriosis who are asymptomatic. And this is in fact the 21-year-old whose endometrioma you just saw being stripped out, and this girl was completely and totally asymptomatic, no pain whatsoever. And the only reason she came to notice was that I operated on her older sister for infertility and found her older sister to have bad endo, which we removed, and she became spontaneously pregnant, and she insisted that her younger sister come along and be checked out, and when we scanned her, we saw these huge bilateral 8-centimetre endometriomas. No pain at all. Just to reinforce that, I think this is a very interesting study. This is by Thomas de Hoog, who's a Belgian gynecologist with a great interest in endometriosis. Thomas has done a lot of the original baboon research. Baboons suffer from bad endo. And Thomas has an infertility practice, and he took 221 infertile women who had normal period pain, so they described. They all had good quality husbands, and they were all ovulatory. And he laparoscoped a lot of them. 47% of them had endometriosis. And you can see that about 40% had stage 3 or 4 disease, really quite severe endometriosis, again, in an asymptomatic population. And I think that data is really interesting. But going back to the pain, as I'm making the point, I think it's very difficult. It's a complex situation that's influenced by all sorts of confounding variables. And I don't think endometriomas, as I said, per se, cause a lot of pain. So I'm not going to talk about this topic anymore. What I'm going to focus on is fertility. And this, just out of interest, is a male frigate bird, all puffed up, trying to attract a female mate. And if you're wondering about the wildlife, last year I had the pleasure of going to the Galapagos Islands, and I just thought I'd take the opportunity to show off a few of my photographs. So, what about ovarian endometriosis and infertility? How important a topic is this? Now, while you're scanning your female patients with endometriomas, if you ask them how important or how concerned they are about future fertility, they'll turn to you and almost invariably tell you that it is the most important thing to them. So this is a big issue. What about ovarian endometriosis and infertility in terms of treatment? What happens in reality is that if you get referred to an IVF doctor with an endometrioma, you'll get IVF. And if you get referred to a laparoscopic surgeon with an endometrioma, you'll get an operation. Now, I don't think that's a really good basis for determining how patients with endometriomas and infertility are managed. So we've got these two, and that's a real photo, by the way. We've got these two approaches. We've got good old-fashioned surgery, and we've got sexy new IVF. So how do we determine who's to get which? Let me just walk you through this paper from Barcelona that looked at 825 patients with stage 3 and 4 endometriosis. The mean size of their endometriomas was 5.8 centimetres. 483 of them elected to have laparoscopic surgery. And of those who did not become pregnant, 144 of the 221 elected to go on to IVF. There were 173 patients who elected to go on to primary IVF, and there were 169, interesting group, who elected to do nothing at all. Now, of those having laparoscopic surgery, pregnancy rate was 54%. And of those going on to IVF after failed surgery, the pregnancy rate was 30% per ovum pickup. The paper didn't give me the cumulative pregnancy rate over a number of cycles. Of those going straight to IVF with their endometriomas in situ, the pregnancy rate was 32% per ovum pickup, and interestingly, only 20 of the patients undergoing no treatment achieved a pregnancy over the next 8 years. If we split the pregnancies by age, understandably we see a much higher pregnancy rate in the younger group, under 35, compared with those over 35, and we see a similar distribution in the IVF outcomes. So what we're looking at, again, and we keep coming back to this figure over and over again, about 65% of patients will achieve a pregnancy spontaneously after surgery alone, and this compares with the IVF outcomes that you can see there. So my primary approach to dealing with endometriosis has always been that in the presence of an endometrioma, essentially one does laparoscopic surgery to diagnose and treat the endometriosis, and then send the patient away for them to try and get pregnant on their own. And if they do, that's great. If they don't, then the next step is IVF. And of course, you short circuit to IVF if you have obstructed tubes or if you've had the misfortune of marrying a poor quality partner. Not all patients want to have surgery, and that's fine, and they can go on to IVF, but certainly if they had 2 or 3 failed IVF cycles, then I would encourage them at that point to have a laparoscopy. So for many years, this has been my simplistic approach to management of these patients. And it's been following essentially the guidelines of the American Society and the European Society, which recommends surgery for endometriomas over 3 centimetres for a histological diagnosis, especially to improve spontaneous fertility, to reduce infection at ovum pickup, to improve access to follicles, and possibly to improve ovarian response, but that's a big possible. And laparoscopic ovarian cystectomy should be considered for patients equally with endometriomas under 3 centimetres. It may interest you that it's far more difficult to remove a small endometrioma than it is to remove a big one. And here's the ESHRA guideline, which says essentially the same thing. However, again, they are highlighting the fact that if the patient has had previous ovarian surgery, you should think twice about repeat surgery. I mentioned before that ovaries in particular do not like repeat surgery. Then there are some warning signs that started to really come onto my horizon, and that is that excising these endometriomas may significantly decrease ovarian function. And we all have patients who have routine endometriotic surgery, don't get pregnant, and when they come to assisted reproduction, their ovarian responsiveness to gonadotrophins is very, very poor, and you struggle to get an egg or two. There's certainly evidence that taking out an endometrioma reduces ovarian volume, and the electrosurgery that we use to achieve hemostasis may also have a significant detrimental effect on the ovarian function. It's a concern about removing eggs at the time of excising endometriomas, and we looked at this back in about 2004. And what you're looking at here is a histological slide. I thought I had a laser, yes I do, showing the active endometriosis surrounded by a layer of fibrosis, surrounded by a layer of ovarian cortex. Fortunately, usually with fairly sparse primordial follicles. Peter Russell and Michael Cooper and myself actually went through the exercise of assessing what percentage of the specimen that we handed to Peter Russell, our pathologist, what percentage of that specimen was ovarian cortex rather than endometriotic cyst. And it surprised us to see that the range was huge. It ranges from 10% of the specimen as ovarian cortex up to 90% of the specimen being ovarian cortex. So the cleavage plane in the ovary is not between the outside of the endometrioma, it's between a layer of ovarian cortex that's drawn down surrounding the endometrioma. So with this concern in mind, I'd like to highlight that there have been 2 events that have occurred that have really significantly changed my practice over the last few years. And the first of these was the availability of anti-Müllerian hormone assays. AMH is a growth factor that's secreted by the granulosa cells around the egg, and it's secreted by the very small primary and secondary antral follicles, or the very small pre-antral follicles is what I mean to say. And therefore, it's the best indirect measure of the total oocyte pool within the ovary. Changes in serum AMH occur fairly early in the sequence of events with ovarian aging, unlike basal FSH levels, which occur relatively late. AMH can be measured at any time in the cycle, which is another advantage, where, of course, basal FSH levels must be measured on the second or third day of menstruation. You can measure AMHs in people who have been on the pill, which is another advantage. So it's a very, very nice way of assessing ovarian responsiveness. And that's exactly what it does. It's giving us a measure on the ovarian responsiveness to FSH stimulation. It's giving us a measure of whether that patient is likely to become prematurely menopausal. It does not give us any evidence about or any information about the patient's ability to spontaneously ovulate. Here's a graph of what happens to AMH as you grow older and you start using up your eggs, and of course your AMH starts to fall. There's a 10th centile line under which we would mark diminished ovarian reserve, and there's a 90th centile line showing excessive ovarian response, usually limited to patients with PCO. And the AMH, it was never designed this way, but the AMH numerical figure roughly equates to the number of eggs that you're likely to get with average stimulation at the time of IVF. So you've got an AMH of 5, you're likely to get 5, 6, 7 eggs with routine stimulation. There started to appear in the literature a number of publications highlighting the impact of endometrioma surgery on ovarian function. And that really started to evolve in the literature at the same time that we were starting to realize that some of these patients may be disadvantaged by surgery. And here's one such paper. It looks at 43 women aged between 18 and 42 years. Interestingly, they all have low BMI, relatively, 21 as average. And you can see down the bottom the split of severity of endometriosis. The BMI is interesting, and again, back in about 2004, yes, it was 2004, we actually looked at some of our own data that correlated the American Fertility Society severity scoring for endometriosis and weight. And it is very unusual to see a patient with severe endometriosis who is obese, which is a great thing for me being a surgeon. It's terrific that the bad ones are in the skinny girls. And this is what happened in this study after laparoscopic stripping and assessment of their ovarian reserve. You can see their basal FSH levels don't change very much. Their inhibin B doesn't change very much. That's a sort of assay that's gone out of favor. Their antral follicle count in the affected ovary actually increases. It seems that the presence of the endometrioma may be suppressing follicular development, but the AMH falls dramatically. Now, this AMH is in nanograms per mil. That's the American measure. We measure picomoles per litre, and you need to multiply those AMH levels by about ×7 to get the equivalent of our current units. But you can see the AMH is falling by about half. And that prompted me to pull out some data of my own. This is a dozen of my own patients who had preoperative AMH levels and postoperative AMH levels. And you can see there's a very, very wide range of AMH levels preoperatively. But in particular, about a quarter of the patients start off with a very suppressed AMH level. And then down the right-hand side of that table, you can see the percentage fall in AMH levels. And it's a bit horrifying. they're falling on average by about 50 to 60%. So taking these endometriomas out certainly is having an impact on the ovary. The second thing that changed my practice dramatically is vitrification of gametes or embryos. Now, vitrification, Genea, the company that I work with, came in 2009. I think it was a Japanese technique where the embryos are literally snap frozen. The culture medium is loaded up with antifreeze or cryoprotectants, and they are literally touched onto a liquid nitrogen block at minus 196 degrees centigrade, and the embryo is snap frozen. It used to be that a frozen embryo had half the pregnancy potential of a fresh one. But since vitrification, and again, this is data that we pulled out from Genea, looking at 2,900 fresh embryo transfers with an implantation rate of 42% versus 1,500 frozen embryo transfers with an implantation of 38%, no significance in that. The only time we actually reached significance was in women under 38 years of age. But bear in mind that historically, those patients having frozen embryo transfers have already had a fresh embryo transfer before. So the embryos that are being put into these women are their second best embryo, because the best embryo would have been used in the initial frozen transfer. But essentially, there's not a lot of difference there between fresh and frozen transfers. And in fact, there's talk all around the world about whether frozen embryo transfers using the best embryo may give you a better pregnancy rate than a fresh one, because the endometrium is not going to be under the influence of the gonadotrophins from the stimulation cycle. We do quite a lot of CGH testing of embryos, and those embryos all have to be frozen because it takes 2 or 3 weeks to get the CGH results. And if you model for what pregnancy improvement you should expect by weeding out the genetically abnormal embryos, the actual pregnancy rates are higher than you model for. Is that because all of the embryos, including the best one, are being frozen and then electively put back in a cryo transfer cycle? Some other interesting data has come out that using previously cryopreserved embryos is associated with a reduction in some intrapartum events, such as abruption. And interestingly, some work from the late David Healy's unit down at Monash has shown a reduction in blastogenesis birth defects when frozen embryos are used rather than fresh ones. So the bottom line is that I don't believe there's any major disadvantage to embryo banking and then putting them back in a frozen cycle. So the algorithm that I currently use becomes suddenly much more complicated. In the presence of an endometrioma, the very, very first question I ask is, what's the AMH? An assessment of ovarian reserve. If the AMH is good and robust and high for the patient's age, then I think they should have primary surgery, followed by a trial of pregnancy, and failing pregnancy to progress on to IVF. If the AMH is compromised, like that quarter to a third of the patients I showed you on my own data, then I think they should have emergency assisted reproduction. And if their endometrioma is less than 5 centimetres, I'd work around it. And if the endometrioma is bigger than 5 centimetres, I would consider draining it off transvaginally to improve access to the follicles. And I did one of those just this very week. Following that, the patient's cycled through an IVF cycle, embryos are created and vitrified. Once you've got a good bank of vitrified embryos, then you do the surgery to improve implantation rates. So that's become a real change in my management, and as a surgeon, for me to be telling patients, no, don't have surgery, but go down this path of storing some embryos is quite a turn. And if the patient doesn't want to become pregnant immediately, but is concerned about future fertility, or they are single, have no partner, then I would discuss with them the prospect of storing embryos for the future again, or storing eggs. The data, sorry, I thought another slide was going to come up. In spite of that, we still see recurrent publications pointing out that IVF is the way to treat endometriosis. But if you drill down in that abstract there, you'll see it states, with the exception of patients with endometrioma. What's the risk of infection? I said I'd come back to this. Very little in the literature, but one paper from back in 95 showed a rate of 1.3%. We do about 4,500 IVF cycles at Geneo each year. We have 1 or 2 ovarian abscesses per year, almost always in patients with endometriosis. So I think with proper surgical prep and antibiotic cover and drainage of an endometrioma under surgical conditions, I think that it's fairly safe to go down that aspiration path. I was going to show you a couple of quick cases, but the lights are flashing at me, so I might just wind up. Thanks for the opportunity of talking to you today. We're all in the same game of trying to help these patients take their baby home. Thank you.
Thank you very much for an excellent presentation on how the treatment of endometriomas has changed over time. Is there anyone with questions?
Jeff, so what advice do you give to us who operate then? So we have a woman with an endometrioma and we're considering surgery. If her AMH is good, you go for it by the sounds of it.
Correct, yeah.
Okay.
If you're starting from a good quality AMH and you can afford to drop it by 50%, go for it. But these girls who've got 6 centimetre bilateral endometriomas and their AMH at the age of 35 is 4. You operate on those girls and in terms of future assisted reproduction, they're going to be hopeless, really hopeless.
Okay. And is there any guidance on, do you just do a one-off level? Does it matter when you do it in the cycle? Do you need to look at the change in AMH over time?
Yeah, unfortunately there has been a bit of a problem with the assay. It's a Beckman-Coulter assay that earlier this year was found to be reading a bit artificially low in some patients relating to their complement levels. That was a real pity that happened, because it sort of just put a little shadow of doubt into AMH assays, but that has been corrected and the assay is now back online and it should be a really robust assay. I only do one preoperative AMH and a number of papers now coming out tracking AMHs with time after endometrioma surgery, and they do not recover with time. So that's my current practice. Okay.
Thank you very much.